through vigilant monitoring and evidence-based practices. His work focuses on active pharmacovigilance, including monitoring, reporting ADRs to the WHO database, as well as overseeing medication errors. Dr. Kumar plays a pivotal role in clinical rounds, quality control initiatives, and serves as an integral member of the Pharmacy and Therapeutics Committee. He actively contributes to the professional development of healthcare teams by conducting training programs for nurses and pharmacists. With specialized skills in chemotherapy and immunotherapy drug reconstitution, Dr. Kumar ensures safe and effective administration of critical treatments. He actively participates in ward rounds, working on optimizing patient medications, and has significant experience in managing bone marrow transplant protocols, including anti infective dosing and daily patient monitoring. Dr. Kumar Sir's commitment to advancing clinical pharmacy practice highlights his dedication to improving patient outcomes through innovation, collaboration, and continuous learning. We welcome you, sir. The virtual stage is yours.
Yes, hi. Thank you for the introduction. Let me just share my slides. Is my slides visible?
Yes, sir, it's visible.
Okay. So, yeah, good evening, everybody. Thank you for this opportunity. As previous session, sir has discussed about how an industry works and how a clinical research works, and how we as PharmD students can get into this and make a difference. So I'm Dr. Delvin. So I'm a clinical pharmacologist in Bangalore Baptist Hospital. So mainly my areas of specialization is oncology and hematology, and also bone marrow transplant. Small note about our hospital is the it is a basically a charity run hospital. So we have quite a lot number of patients, and as sir was discussing about hospital settings of clinical research, we still haven't got any clinical research department yet, but then hopefully in future we will look into that and try to get one. So today my major discussion points will be about in hospital settings. So in hospital settings, our major regulatory boards are NABH and JCI. So JCI is these NABH and JCI, they have a set of rules and set of they have a textbook basically of what and all should be done controls, nursing department, rooms, all those things are included in this NABH. And I'll be discussing about a few of the documentation, whatever we have to be doing. And this includes in the bone marrow transplant unit settings as well. So I think many of the participants are students who are in fourth year, fifth year, and sixth year. So, and this is the phase where even I was also confused as in to go where. Is it clinical side, or do I go towards research? Do I go to pharmacovigilance, or do I go for higher studies? So I think this whole conference will give you a rough idea and narrow down your path to what you actually require. So before starting this, so let me just tell you about how I work in my hospital. So my work is basically clinical work most of the time. So I this audit works, I just minimize my time to it. And since there are already specialized quality department working around me, so they look into it and I just give some suggestions or inputs as in when it's required. And majorly I participate in OPD with the medical oncologist, and sometimes during hematologist as well. So largely I see solid tumor patients in the OPD. And now you might be asking, what will a clinical pharmacist do in a OPD with the clinician? So our basic role is to in our oncology, it's a day-to-day basis. So we'll be calculating the drug doses based on the patient body surface area, based on the patient lab reports, based on the patient. Sometimes you might see the lab reports may be telling some story, but clinically, when you see the patient, he might not be the same as his lab reports are showing to us. So, and that's in that scenario, we'll have to make a clinical decision. So I'm actually very glad that in my hospital they accept this clinical aspect of a clinical pharmacist as well. So usually I do decide on what drugs to be given and procurement of these drugs, because most of the newer therapies, because all I think highest number of researches is happening in field of oncology and hematology. Moreover, lately, because the amount of patients and the cost involved and lot of new drugs. Basically, in this entire year, if you consider, there are a lot of new drug approvals coming under NCCN and FDA. So we have to be updated with that. Apart from that, we also involve in preparation of all these immunotherapies and chemotherapy drugs, because uh, drugs are high risk medicines as we classify, and one majorly because of the therapeutic interest, and other thing is it's also harmful to the person who is preparing it if it's not done in a right way. So major, so let me just discuss basically about this NABH. So I'll not go deep into this. So the NABH has basically a fifth edition, of which there is the third chapter, which is of importance to us. So which is management of medication, where we deal with all this medication reconciliation, prescription audits, and all those things. And the same applies to JCI as well. So these are all the list of things that are coming under medication order management. So whatever we are doing, so how the drug should be prescribed, how it should be written, how a prescription should be given to the pharmacy, how a pharmacist will interpret the prescription, and how we
The
are
slides are not moving.
uh, okay, just a second. Can you see the slides now?
Yeah, sir. Now
Yeah.
it's clear.
Okay, so all these things, and our role just does not end in OPD. So it ends until the patient is receiving right medications. So because more of the drugs are like look alike and sound alike medicines, and this is where, as a clinical pharmacist, as studying PharmD, will help us a lot, and give us an edge over nursing staffs and the nursing supervisors, because
Indian Barcelona.
yes,
Yeah, I work here. You don't know for me,
yeah,
welcome.
yeah, this I think, yeah, okay. So
Sir,
our our course is
can see.
relatively new compared to all the courses that has been introduced in hospitals settings, because I think 2008 was when it started, so 6 years, so roughly around 10 batches, less than 10 batches have come out. And if you see in most of the hospitals there is either one or two clinical pharmacist or clinical pharmacologist posts that are being given. But lately I've been seeing in my circles, oncology is one of the fields where it's the job opportunities are improving a lot, and even the pay scale. Earlier it was very less, so it was basically around 20,000 a month, so which is very less compared to what you have invested in your studies and what you're looking for. But currently, if you are having good experience, good what you will tell, a sound knowledge about what's happening in the field of oncology and hematology, people are willing to pay you more in the sense you might get around 40 to 50 a month, or yeah, and it also depends on the regions where you're working. So comparatively in North India, the pay scale is slightly higher, where you'll get roughly around 70 to 80 a month, ranging based on your experience. It might increase as well. So that is the things. And so if you go to the next, um, how do we organize the wards? So what are our basic functions? So first one is selection and procurement. So this thing will be taken care mostly by the pharmacy and the pharmacy manager. So where we will play a role is in the storage unit, where we have to see all the medicines are stored in the right temperature controlled rooms, and according light sensitivity, and all based on the look-alike sound alike drugs. So our drugs mostly are refrigerated drugs. So once the drug is frozen, and it is frozen into less than 2 degrees, the drug becomes useless. So basically, the all these drugs are proteins. So when you froze it, when you freeze it into that temperature, all these things get denatured. So even if you're infusing that same drug after defrosting, the drug might not give you the same efficacy, or it might not give you the same expected results. And another one is ordering and transcribing. So this part is mostly handled by the nursing staffs here. And nowadays in many of the hospitals, everything is electronic and used in EHR systems. So it's quite safe and like easy to understand, rather than compared to the earlier days where we had to prescribe handwritten prescriptions, which were more confusing, and there are, tend to be a lot of errors in this session, in this area. And next one is preparing and dispensing. So dispensing part is handled mostly by the pharmacist, that is in the pharmacy, outpatient pharmacy. And preparation part is where we the clinical pharmacist take over, because earlier days, when you compare, when you see the history, what was happening in oncology settings is the nursing staff, the usually the senior nurse or the nursing in charge used to prepare these medicines, because all these medicines are very expensive. As you see, it's a lot of amount is spent on clinical trials and to getting the drug into market, a lot of time, 10 to 15 years, which is spent on this. So the once it comes and it's in its patent period, the cost of the drugs are very high. So it's ranging from 1 to 2 lakhs per vial, 3 lakhs, 4 lakhs. So lot the cost is very high. So you also we require an additional responsibility of, like, you have to prepare it right way. So that's the major thing. And another part is administration. So when you are going to administer the medicines, so since we are clinical pharmacists, we do not have a legal right to administer medicine to any patient. So it will be done by a registered nurse, but you can definitely supervise the medicine. So for that, you will be requiring a bit of nursing aspects as well. So IV canalization or different types of IV accesses that you can get, either chemoport or through PIC line or through central lines or EJVs. And take how do we maintain these lines for as long as possible without getting any infections and any port infections or any site infections. And another one is monitoring. So since all these chemo medicines which we are giving is a foreign body, so once the foreign body enters our circulatory system, our T cells and our immune cells respond, and there are chances that this can give you some infusion reactions, as we call. So we don't call it as adverse reactions as such. So if you see any drug leaflet or drug manufacturing labels, so there is a separate column telling about infusion reaction. So most of the monoclonal antibodies tend to have infusion reactions, but I think it is manageable. It's not like very severe. So grade 4 is very rare. Grade 3 or 4, it's usually grade 1, or sometime more, or sometimes it's not. And if you see in like conventional chemotherapies where we use paclitaxel, carboplatins, and all these platinum drugs, uh, these drugs have tend to have some reactions that will be based on the composition of the drug, the formulation of the drug. So most of these drugs have reactions based on its excipients that are present. So we ideally give pre-medicines with nausea, anti-nausea medicines, anti-emetics, and all the anti-allergic medicines as well before administering these medicines. So our role in this part is to ensure that all the medicines are given at the right dose, and there are certain contraindications as well, so we can look into that. So first thing is how do you prepare for a ward round? So I think in if you go to conventional or college settings, so it is just a casual rounds, because in my internship I used to just go hang around, chill around, and then see one or two patients and then come off. But when you are completely working as a dedicated clinical pharmacist, you cannot be doing that. So in my daily clinical practice morning, we just go to all our inpatients. So not just our chemotherapy daycare patients, will be having supportive care patients. So oncology is one field where if you ask any medical oncologist or hematologist, all these protocols are standard. So if you see throughout the world, whatever we are following in our hospital for a particular cancer, say for example a particular type of breast cancer, this protocol is similar, these drugs are similar throughout the world, this dose is similar throughout the world. If you go to US and take the same treatment for the same cancer, it will be same. So the major challenge for us is how do you manage your supportive cares. So that is one of the major things. So first thing, as we see, I just follow up with all the lab reports that we are sent for that day. So usually in our hospital, we send out the lab reports at 6 a.m. So that by the time we reach, the consultants reach, and by the time we reach the patients for pre-rounds, the reports are ready. So by around 8:30, the reports are ready. So I have a the log book with me. So for each patient, which each day wise, whatever we monitor. So for example, any chemo patients will be monitoring for neutropenia, that is for CBCs and LFTs, creatinine, and any other if suppose there is any infection, so the culture reports and the procalcitonin reports, and furthermore. So I'll make a list and note down all the things, whatever is whatever the that day, and this includes the scan reports as well. So since I think many of us denote ourselves just to be clinical aspects, just to see the drugs interactions and see the dosing and see the things. But for that, more important, we have to correlate with the scans. So the to that, it will give us that if our drug is working right. So like if we are giving, for example, a drug A for a patient, say for example, if any patient is having any constipation or any severe diarrhea, so we'll be taking an erect abdomen X-ray, or in further cases we'll be seeing if there any CECT scans we will be doing to see if there is any obstruction. If there is any obstruction and if the patient is having constipation and you're trying to give metoclopramide, that is GI motility agent, so it does not serve the purpose because the intestine is obstructed. And what are you trying to do? So that's when we have to try. I'm not telling that we should have complete clinical knowledge about how to read an X-ray or CT scan. We can go through the reports as well and see that that's sufficient for us to see that we are in the right path in choosing the supportive drugs. And then we just go to the patient for that day and we see if all the medications are being given at the right path. And then we'll also number the antibiotics. So one of the major concerns and one of the major booming fields for us as clinical pharmacists is antimicrobial stewardship clinical pharmacists. So there are private firms and many of the government hospitals are also trying to looking pull in these clinical pharmacists to ready to cut down this antibiotics use, because as of now you see any newborn baby also, if there is any cough fever they start off antibiotic. So I recently had an experience where a small boy, 4-year-old boy, is having multiple antibiotic resistance. So just imagine, he just lived 4 years of life and we have managed to give him resistance to all the antibiotics that are available in the market currently. So that's where our role will be critical. So I'll be discussing this with the small case where we have seen how we do. And next thing is a patient relationship. So the more important is like how you deal with your patients. The patients, the more they are comfortable with you, the more they are open to you, the more they will tell you about their problems. So like if they don't even reveal the problems, it's very difficult for us to assess the patient in clinical aspects as well as the medication aspects. So that is thing. And another one is nursing care team. So all of us work as a team, the consultant, clinical pharmacist, nursing team, and also even the nursing aide who provides assistance. So they are all part of our team because they are. I usually we think that the nursing aides, what is their role? How will they help you? So they are the ones who help us to report any bed sores or any any part of the body where there is any infections which the patient is trying to hide or is not willing to tell it openly. So so in that cases they help us to deal with all the things. And then pre-rounds we make a note of all the things and all any electrolytes to be corrected, any medications to be changed or antibiotics to be changed. All these things I just make a note of it. And then there will be a rounds with the doctors. So during this rounds, in my settings, the consultant will straight away ask me and the resident doctor what to be done. So you are treating the patient. What is your role in this patient? What you will be doing? So in that case, with me, the resident JMO, they will be assessing the patient clinically. So along with that, we can also assess with them like how our drug is helping them. How like is it making any difference, or is this the right time to start a medicine or stop a medicine? And then post rounds. Post rounds usually happens in the noon time or evening. So during rounds, if there is any new tests ordered or new medications added or new any new since I work in a multi-specialty hospital, so we give out referrals to other departments. So any new referrals to another doctors like gastroenterology, orthopedics, or any pulmonology, any new references has been given, and what they have come and told, and what are they wanting to add, or what is their inference about the current condition. So all these things we make a note, and then we go for post rounds. And along with that, in our settings, the consultant comes for rounds twice, that is in the morning as well as in the evening, to ensure that all the things for the day is carried out. So this basically happens with the inpatients who are admitted for supportive cares. But if you're seeing as daycare settings, the oncology settings, so all these patients just come in the morning, take chemotherapy, and get discharged by afternoon or late evening. And so these people will be seeing in the OPD. And as a clinical pharmacist, our role is to counsel the patients for medicines. So now, as you know, immunotherapy, so it costs around 2 lakhs per cycle. 2 to 4 lakhs. So I'm working in a hospital where the patients who come here, their annual income is only around 4 to 5 lakhs. So in that case, we have to try to get them some support programs or some company assistance programs, that we call it as PAP programs, patient assistance program. Try to get them, enroll them. Or you check in the international markets where the drug is not available in India, but through any portals or through company helplines, you can procure the drug from international market and give it to the patient, which will help them. So these are the things. And now during rounds, we, as part of audits, so we'll be checking for all these errors, that is prescription error, transcription error, administration error, dispensing errors, and monitoring errors. So I'll not go deep into this because I think this is our daily clinical practice, which we will be doing in our college life and college settings. So beyond that, I want to discuss something. So to as we know, whenever we are pointing out any errors, so when the major part is how do you convey this to a consultant, because a consultant is we have studied 6 years of PharmD, say post 6 years you have done some fellowship courses, say 6, 7, 8 years you keep it, but they are a specialist, so they usually take some 10, 15 years to be a oncologist, medical oncologist, fully fledged. So in such cases, there will be a particular way how do we approach. So in my settings, I use, if there is any changes that I want to do. Suppose, for example, if any pre-medicine is not required, for example, dexamethasone, the steroid, I want to reduce the dose, so I would just go to the consultant and ask him, like, is it possible that we can reduce the dose so that the patient also is not requiring this dose at particular at this time, since his glucose is out of range or it's deranged, so can we reduce the dose. So in such, and with the proper clinical evidence, so we need to present clinical evidence, because as of now in India, nobody is seeing a clinical pharmacist into as a clinical side, where you just come and tell something and they'll blindly accept. It's not, as of now, that's the case. So it all depends on how you build your trust with the consultants and the treating team. So that's one. So for me now, I'm in this field for around 2.5 years now. So if I suggest something, they usually do it. Like most of the time, the consultants just tell me, just go and add of these antibiotics, just check the dosings and make as per you want, whatever medicines you want, and they'll just tell me, if you require to change anything to oral formulation, please do it. So all these things. And other thing is administration errors. So this thing is majorly happening from the nursing side. So how do we identify administration errors? So we have different patient identifiers in hospital. So if you go to a hospital, they'll give you a hospital number. If you get admitted, they'll give a nice ID band, so with your hospital number, name, and all your identifiers. So what I have implemented in my ward is that before administering any chemotherapy medicine, the label of the medicine has to be cross verified, Even though when I am preparing the medicine, I cross verify it with the nurse in the ward. And since I'm the alone clinical pharmacist working here, so I cross verify with one nurse. And before administering the patient, the nurse who is going to connect the medicine has to cross verify with another nurse in the particular ward. So this double checking system ensures that even if I have missed on something, there is a chance that they can catch that thing, and ultimately the patient will not be affected because of this. And another one is monitoring error. So most of the times we don't give instructions to nurses, like as in what to monitor, how to see, because many of the nurses, they are already very busy, because in our hospital settings, the nursing staffs will have to see at least some 6 to 8 patients in a day, each nursing staff, I'm telling, in their particular shifts. So when if you say for a patient A you do send off CBC, the nursing staff will be so busy, they might miss it on and send it to a patient B. So in that case, we will have to be checking with the elixir when the test, like we have a elixir system, that is the EHR which we have. So when the test is raised, and all those datas. So medication reconciliation, I'm not going to go more deep towards it, because in my hospital settings, the quality department is there, which is including the doctors and a few of the B pharmacy students with MD pharma, I mean the M Pharm pharmacology people, who will be checking out on all these things. So all the drug names. So this is majorly important when the patient is shifting from one ward to another ward. Say for example, from ICU to a step down ICU, or from a step down ICU to a ward. So this ensures that whatever the medicines that are been going in the ICU is continued, and whatever is meant to be stopped is not given in the ward. So proper handover and communication is given. So this is one of the major things that I wanted to justify, like what is this antimicrobial stewardship program. So until this things, I've not gone more into a bone marrow transplant unit, how it works. So I'll be coming to it in a bit. So antimicrobial stewardship, we have a HOD of critical care, that is the ICU consultant, because ICU HOD is ICU in our hospital. We have a 50 bedded ICU unit, that is just the HICU and the intensive care unit. So for in any given point of time, there are at least 40 to 45 patients in ICU who will be receiving high end antibiotics, that is ceftazidime or any azithromycins, meropenems. So as a clinical pharmacist, I don't usually go and see any general medicine patients there, but then when any of our oncology and hematology patient goes to an ICU, goes to ICU for any reason, so in that case, I do go and I just see the antibiotics, whatever is going on. So this is the ICU team, whatever is there for antimicrobial stewardship program. What is the major thing? So first we have to start the antibiotics. So if you go and ask any consultants or clinicians, so even before the culture report comes, if the patient is having fever, so for example, in our day-to-day basis as well, you are having some cough, you just go take off some azithromycin or amoxiclav, and you just come off. So this is what we call it as empirically we start off antibiotic. So usually the empirical antibiotics most of the times is right on path with the culture, but sometimes we might miss on. So some of the rarer bugs may be growing in this thing, in the culture media, or in the chest, or in the gut, or in the urine. So in that case, our So before starting antibiotics, so we have a protocol that we have to send a culture from any particular line. So one is peripheral blood, that is from your IV axis, and another one is if there is any central axis, central lines, and another one is if there is any port, chemo port, or any peripherally catheters. From that catheters we send off cultures to see the source of infection. The major treatment of any infection is to eliminate the source. For example, if the source of infection is the catheter, we have to remove the catheter, and then possibly if the patient is requiring catheter, maybe in once the fever is subsided or counts have picked up, we can recatheterize the patient. So in our oncology settings, most of the patients are neutropenic, that is their immunity is very low. So our normal WBC should be 4,000. So I usually the recently today I have a patient with the count of 100. So the WBC count is 100. So in that our immune cells are neutrophils. So neutrophil is out of 100, some 20 cells. So you just imagine how if you leave the patient alone, definitely the patient is going into sepsis and is going to succumb. So in that case, we will have to give for antibiotics. So what are the signs of infections that we have to observe? One is fever or any external catheters, whatever is there, or any severe diarrhea or burning maturation. All these signs we have to monitor. So these are the indicators that if our antibiotic that we have started empirically is helping them or not. So as we told, usually the culture reports will come in 48 to 72 hours. But in our patients all are neutropenic. So I usually go the next day morning to the microbiology lab and myself check the culture report with the microbiologist. And if I'm not convinced, so sometimes there will be common cells organisms. The common cell organism is nothing but whatever the organism bacteria that is there in a normal individual in their gut or in their body. So I myself verify the petri dish at times. So in case if the patient is curative or like your intent is to cure the patient, most of the times our oncology settings, if it is a stage 4 cancer, we all know that the chances of cure is very minimal, less than 10%, or sometimes extensive metastasis, it's almost zero. So that's why, sorry. Okay, I think, yeah. So in that case, we just review the culture sensitivity
ಲಾಸ್ಟ್
report.
ಕ್ರಿಸ್ಮಸ್ ಬಂದಿದ್ರು ತೆಲುಗು
So in this,
ಲೈಟ್ ಹಾಕ್ಯಾರ ಅಂತಂದಿದ್ದಲ್ಲ.
I think somebody is on.
Audience, please unmute yourself.
Yeah, so in such case, we just see the culture and sensitivity report. So one great fact that I'm going to tell you, the culture machine in any of the hospital settings is only 30% sensitive. That means that out of 100, only 30% chance that it will pick up a bug, and it will tell you that this bug is there. So there are 70% major chance that it might not pick up the drug which is actually causing the infection. So in such cases, it's a very tricky scenario. So coming to the modern, now we most of the things have gone into genomics. So there are NGS panels. So NGS panel will give you around 90 to 95 to 98% sensitivity. So it can be applicable for even viral bugs as well. So in such cases, we just go and see the culture. So along with the culture, there will be the sensitivity pattern. So if you have observed in your hospital what antibiotics are sensitive to this patient, so we'll just see if we are giving. So I'll just discuss a case later on, a small case scenario, so that might help you with how to go ahead from this. Another thing is high risk drug monitoring. So all antibiotics, for example, the high end antibiotics that we are using, and the electrolytes and psychotropic medicines, anti-diabetic medicines, all this drug monitoring should be done. So what I do in my daily practice is whenever there is an
See, your voice is not audible.
Sir, your voice is not audible, sir. Please unmute yourself.
yeah, can you hear me now? I think it got muted.
Yes, sir.
Yeah,
Yes, sir. We
so
can hear you.
yeah, so as per what we follow, what I have suggested with our junior consultants, whenever we write a new drug chart, so we add antimicrobials on top, and then we add any of these electrolyte corrections. So for example, in case of IV corrections, so we have a designated space outside the major drug chart where we only write for IV corrections of electrolytes. So in our hospital, so this helps you to reduce the confusions, and these all are very narrow therapeutic drugs, so you cannot give as in required. So in this, our role is the infusion duration, infusion time. So for example, if you want to correct a potassium for a patient, say a potassium value of 3 for example, and I don't want to give an oral correction because for say any reason the patient is having some esophagus tumor or something, so because of which we cannot give the oral correction, I want to give IV correction. So if it is 3, so what we usually suggest is 40 MEQ or in 500 ml NS over 4 hours. So the standard guidelines for potassium correction, if it's peripheral line, you have to correct at 10 MEQ per hour, because potassium is one of the electrolyte that is required for your cardiac functioning. So if you can't just give it as IV push as you take any normal injections, for example say paracetamol or diclofenac injections. So if you by in chance, if anyone has given it IV push, it's hardly 5 to 7 minutes the patient will go to cardiac arrest. So it's matter of life and death at this point. So we have separated out these things, and then next one is insulins. So insulin is also one of the major things. So uh, what we do is we just write off sliding scale, and then we have a glucose monitoring chart. So in that glucose monitoring chart, so the endocrinologist they call the resident endocrinologist for each reading. So the resident endocrinologist will take the value of how many units of insulin to be given, and the administering nurse will sign over the order and will write the person who has given the order for the same. And next one is narcotics, opioids and sedatives. So in our oncology settings, this is like very commonly used. So one of the major common thing is morphine, because many of them come with lot of pain. So we usually give morphine. So say for example, if there are 10 patients, at least 4 to 5 patients will be on morphine at least 6 times a day. So these all things, you might be asking me, it will make them addicts and all those things, but at that point of time their pain is more concerned, because quality of life plays an important role over there. And opioids and sedatives, we do use sedatives, but then we usually go for lorazepam, that is sublingual, in case if required. And in our settings, the sedatives that we use is more mainly to relieve anxieties. So like we don't go for that higher doses like what we use in any psychiatric conditions or any other like withdrawals conditions, or some like intubation requirements like that. And next one is chemotherapeutic agents, whatever we use. So we have a separate drug form for that. So where we usually have now made it electronic. So the like prescription error can be reduced. And another one is heparin and anticoagulant. So if a patient is scheduled for any procedures, so when do we stop heparin, when do we stop anticoagulant? So as of now in the market there are more novel anticoagulants, so rivaroxaban, dabigatran, apixaban, which is also available as generic. So in my hospital we'll be majorly using rivaroxaban, so we don't have to uh, bother much about the PTINR or APTT status of the patient. So, but we do have to stop the anticoagulants before any procedures, invasive procedures, as such. Um, so, and the next part of our role is to counsel the patients about discharge medicines. So as of now, when we are there will be a lot of supportive medicines, for example immunity boosting injections, and any steroids to reduce inflammations, or any like sleep medications or sedatives, or calcium supplements, vitamin supplements. So it's our responsibility to uh, ensure that the patient is getting the right medicine. So this so happened in my experience, one of the nursing staff, for example, this whenever we give morphine, we'll have to give bisacodyl, that is the tablet that comes as 5 mg. And there is also a formulation called bisacodyl suppository, rectal suppository, that will be given in case of the in case when the constipation is persistent. So for one of our nursing staff has entered suppository to a patient. So it is practically impossible to give a suppository orally because it's like a bullet. It is this big. So you just imagine, just you show down a bullet into your throat and you tell the patient is taking, because some of the patients come there blindly believing you tell them this, you have to take it, they will do it. So it's our responsibility to check that the right formulation is going on to the patient. And patient counseling, as you told, so this thing, and narcotic audit. Anyway, we do have NDPS Act, and usually in our hospital the narcotic audit will be done by the drug controller. Usually once in 3 months they come, and we have a separate forms for narcotic prescription and usage and all those things which will be monitored. And next one is PTC committee. So PTC committee we discuss mostly on like how any new drug to be entered, any new changes to be done. And along with this PTC committee there is another thing called as our team discussion. So for example, and from now on will be, and another next point is ADR monitoring. I think I don't need to go through this thing, is like everyone has seen this form. So now, so the next one is I want to tell you like how a bone marrow transplant unit functions. So basically before we screen for patient for the transplant, we have to screen for donors. So there are two types of bone marrow transplant that we will be doing usually. So one is autologous, that is the stem cells of same person is taken out and it's infused back to the patient with after like we kill all the abnormal cells. And another one is allogenic transplant, that is any matched donor, maybe most of the times it will be the siblings or the parents or any first degree relatives of the patient. From them the stem cells will be taken and will be transfused to the patient. So whenever I tell bone marrow transplant, it sounds like some big procedure. It's painful procedure. Actually the pain in this procedure is not much. The thing is complications, that is the major thing that comes through. So as a clinical pharmacist, so we have to prepare our BMTU. So BMTU is the bone marrow transplant unit. So in our hospital we have a 4-bedded BMTU unit. So before any patient is being shifted to bone marrow transplant unit, that is 1 week before, the first protocol is you chlorinate the entire water. So all this BMTU has separate airflow, separate water connection, separate water tanks, and separate laundry bins, and every and separate washrooms for the attenders, and separate geysers, and separate like heating equipments, and all things are exclusively used only for BMTU, so we don't use it. So we chlorinate the tank so that all the pipes and whatever the things are there, uh, the water, everything is chlorinated, and then we do disinfection. So after that, we do fumigation of the entire BMTU. So this will last for at least 1-2 days. So this all procedure happens 10 days before we take up a patient into the bone marrow transplant unit. So after that, we take a culture of bone marrow units, that is culture from the surface, and culture through the AC events, culture of the water, and all these things, and we'll see that if the culture is negative. If it is not negative, repeat the process again. So until we get a negative culture, we have to do it. That is the thing. And then next major thing is we see that all our emergency equipments, that is the crash cart, is completely filled. So in our BMTU crash cart, I have made it more mandatory to keep defib as well, which should be charged completely at any given point of time. So this happens. So in
Can
the
you change the
yeah, no, this thing is not in the slide. So yeah, the next one is case. Okay. Yeah, so this thing happens. So I have a particular notes for this. So you can get in touch with me through LinkedIn. So about the process, because I didn't add on to this because it makes it into another 40-50 slides. So it is a huge slide. So after that, what we do is uh, uh, we just see all the emergency cart, everything is ready. Say for example, defib, the intubation equipments, all those things, and this should be at least three in numbers minimum. We have one defibrillator, and one more will be kept outside in the chemotherapy ward just in case of emergency. And then all the linens that are there, that is being used inside the BMTU, has properly disinfected. So once the patient comes into BMTU, the patient will be getting only proper mineral packaged mineral water, and no other source of water. And then all the water will, whatever they will be using for their day-to-day purpose, also will be properly distilled and filtered water that will be given to them. And so first phase of transplant will be conditioning regimen. So this will be high dose chemotherapy. So basically it is done to kill your bone marrow. So when say for example, in your bone marrow there are different types of cells in your bone marrow. So all since the patients with AML or leukemias, lymphomas, all the bone marrow is the faulty part. So we have to kill all the bone marrow cells and make space for the new donor cells. So this is the toughest part actually, because all these drugs are highly cytotoxic, and it can kill if it extravasates. For example, if usually we give a central line access for this patients, because if this drug if you are using any peripheral line, if the line is not perfect, then if it extravasates, you have to cut off their hand only, because it will eat off your entire muscles over there. So we give high dose conditioning. So there are different regimens, and that I'll not go into deep. So I have a book with me. I can share it with you guys if you are, if anybody is more interested to learn about these things. And then high dose chemotherapy we give. And the one of the major side effect is mucositis, because the chemotherapy will kill all the fastly dividing cells. So that's when you see many of the chemo patients is having a hair fall or mucositis. Mucositis is nothing but the GI membrane. So from your mouth till rectum, this is one of the fastest dividing cells in the body. So there will be a lot of mucositis. So, for example, you say you have one ulcer in your mouth, so it's very difficult for you to eat. So, imagine this same thing happening 1,000 times more to a bone marrow transplant patient. So, in that case, we have to daily observe the patient for any mucositis, or during the infusion. So what we follow is during the infusion we give any cold substance, for example any candies or like the frozen ice juice that like it's in ice cube form. So we tell them to chew in the mouth during the infusion so that the blood vessels are constricted and very less drug is reaching the mucous membrane. So this has helped us in reducing the instances. But then there will be instances, and then next is all your immune cells and blood cells are gone. So basically there is high chance that you'll get infection. So at this point we will be in charge of starting antimicrobials. So for me, I just get a call around night 1 o'clock. Sir, the patient is having 100 fever. So we have to start meropenem. Can you just tell me the dose? So whatever the drug wise dose, for example, meropenem, we start at 15 mg per kg. So we calculate and then we tell them to start the dose. And then next other thing is during the stem cell infusion, this is the most easiest part actually. The patient will not be having any reactions or anything, so it will go on smoothly. Then post stem cell infusion, the engraftment period. So firstly your neutrophils has to get engrafted and your platelet has to get engrafted. So during this time there is lot of challenges. So first thing is GVHT, that is graft versus host disease. So GVHT can happen anytime, any site, for example, skin, gut, or anything like that for that matter. So we should be prepared with the GVHT protocol. And another one is opportunistic viral infections. So the CMVs, then PCP, and all these things. So prophylactically we start off antivirals and antimicrobials along with whenever we are starting, and antifungals, because fungal infections, if they catch, it's very difficult to treat, because at this state it will be very severe and it can be life threatening also to the patient. So during this period we give off all these prophylactic anti-infectives, antifungals, and antivirals. And usually in a normally settings, during day 7 to day 10 the neutrophils get engrafted, and post that using within 21 days the platelet get engrafted. So now the question is, how do we know? So for example, neutrophils, so we'll usually give neutrophil boosting injections, so filgastrams or peg filgastrams usually. So the neutrophils and the count should be above 1,000 for 3 consecutive readings, and platelets above 50 to 70,000 3 consecutive readings, and it should be in a upward trend. So that's when we tell the patient has been the bone marrow has been successfully engrafted. But in as clinical pharmacist in bone marrow transplant unit, as I told you how I prepare myself for rounds. So I have a list of all patients in a small book. Small book in the sense I've made out a page with all the lab reports daily. So we'll be doing CBC, creat, LFT on a daily basis for these patients, and if any other cultures as per requirements. So all these things we will see. So that will help us to identify any upward trend or downward trend in the lab parameters. And suppose if there is any GVHT or any viral infections, so next thing the a bone marrow transplant physician will tell, you are a clinical pharmacist here, you have to tell me, suggest me something. So for example, say the patient got a bug and then it is resistant to all the organism. So at that point of time all of us will be breaking our head, what do we do now, what do we do now? So we just have minimal time. If we don't act for a day, you might lose the patient next day. So we just try to find out all the combinations that is possible. So we just go. So at that time I do my research and I just take out articles, take out any clinical trials which is suggesting that in say for this bug even though the resistance rates is showing higher. If the MIC is less than 8 or if the MIC is less than 4, it might help. And along with that, we add some prophylactic other antibiotics. So for example, so this is one small case that I've put up. So it's a 35-year-old male patient with acute leukemia. So we had started on chemotherapy with regimen called FLAG. And his treatment, he developed febrile neutropenia, that is fever with lower WBC count. So on empirically, we had started injection meropenem, and we sent blood and urine culture, and patient was hemodynamically unstable. So that is nothing but patient is in sepsis now, means his heart rate is low, or any one of his organs is failing at this stage. So we started on colistin and teicoplanin. So for us as a clinical pharmacist, we have to be knowing the spectrum of action of all these antibiotics whenever we are starting. So for example, meropenem, we say it's a broad spectrum antibiotic. Colistin is gram negative and teicoplanin is gram positive. So now we started, and in the second day the patient is still spiking fever, so we added of colistin and teicoplanin. So this will give you exclusive coverage for gram positive and gram negative organisms, whereas meropenem also will give you gram positive gram negative coverage, but it is not as potent as this colistin for gram negative and teicoplanin for gram positive. It does not cover all the organisms. So after 48 hours, the culture is revealed E. coli. So what is E. coli? Anybody can tell me, like, what is its gram staining status? What is it?
Gram
Anybody?
negative.
Yeah, it's a gram negative organism. So in our antibiotics here, uh, what is helping? What is not required actually? Since we already know that we are the patient is growing gram negative bug, is it really required to grow cover for gram positive organism exclusively, that is teicoplanin? Because meropenem is also covering some gram positive organisms, so it does not require. So as a CP, what we do, so so this is our drug chart here. So I have put off this. The microbiology report, it is telling sensitivity to all gram negative organisms. So you might be asking why you are not starting lower end antibiotics here. So for example, cefotaxime, cefepime, ciprofloxacin or something like that. So since, as I already mentioned, you can see the TC count on the left hand side in the slide. The TC is telling 0.15. So that is very less. And neutrophil is 0.2. And you can see the platelet count, that is 20,000. So in these cases, you cannot go to lower antibiotics, for example, any cefoperazone sulbactam or piptas or anything, because in a general world scenario, we have been using these antibiotics like one bread and butter from so many years that most of us are already resistant to this, already resistant to the most of the bugs are already resistant. So at this point, with counts only 150, with your immunity power so low, you will not risk starting a lower end antibiotic. So that's why we started off with meropenem first. So meropenem will cover gram negative as well as gram positive. So for extended coverage, we have added of colistin and teicoplanin, since the patient was still uh, going for having spiking fever. So now after this report, what as a CP, what is my intervention, you can see there. So consider to stop teicoplanin, and in view of current culture report. So bread culture growing E. coli. So that's where we have stopped. And you can see on left hand side on top that I have mentioned all the antibiotics that are going. So at this point, we had started on imipenem cilastin, teicoplanin colistin, and amphotericin B. So and tigecycline. So after this report, we had cut down the antibiotic to meropenem and colistin. and antifungal coverage, that is amphotericin B. That's all. So in this way, we have cut down three antibiotics, so that help to reduce the cost one way, because this teicoplanin and meropenems and all per dose it is some $1,000. So in a day you require three doses, so 3,000 for antibiotics. So just for one antibiotic in a day, so you'll require for 10-14 days, the antibiotic cost only will go up. So, and it is not necessary, and you're not making any difference in the patient general condition by adding this antibiotics. So we write off and we send, and this intervention is accepted and we have changed, and the patient successfully came out of infection. So the next culture report, it didn't grow anything. So I think that's all for today's session. So you can ask me like any question. So now one major question that I come across is how to prepare for interview, and like as in a hospital clinical pharmacist. Like how do we get into a clinical pharmacist in hospital? So major thing is you have to be strong in your basics. So if you don't know about the drugs, like if you don't know, no, none of the consultants will take you seriously. So you cannot just be telling something based on some previous memories or something, because the field of medicine is updating every day. So something new is happening. That too in field of oncology, something new is happening every day. Some or the other new molecule is coming in, some or the new things are coming, so you have to be updated. And other thing is, apart from your the normal clinical subjects, during your internship I would suggest like you can take for a specialization. For example, there are some hospitals which are taking a specialized hospital, that is single specialty hospitals, say cancer hospitals or nephro hospitals or cardio hospitals. So I think in like in your internship of 1 month, if you were able to take out time and take do internships here in these specialized hospitals. When you finish your course and you go for an interview, you'll definitely have an upper hand. So when I am choosing one person to work with me, I will definitely go for person who is having oncology experience, like who is handled oncology patients earlier. So that is one thing. And another thing is how basic things you'll have to be preparing with these NABH. So this is one thing, because most of the hospitals are going for NABH itself. JCI is very less. Only I think Apollo and Fort is as of now, and Aster as of now is having this, and Reliance, if you're going for Mumbai, Reliance and Leelavati hospitals and all, they are having this JCI accreditations. But most of the hospitals we are having NABH. So it's basically same. So you did not have to go much extra for that. And other than that, you have to decide on what you want to do. You want to go for auditing, or auditing just come see the file, audit if the physician has signed, if the nurse is signed, if the drug is written correctly, spellings are correct, or all those things. Or if you want to go for a pure clinical side where you can make some difference to the patient. So if you want to go for clinical side, you will have to work on this. So when I started as my career in oncology, I still have one book. So this much 200-page book where I restarted with my studies again with oncology, because I was that student who skipped that cancer chapter in third year of PharmD, telling him it's okay, remaining I will study. But then finally my destiny led back to that same chapter which I had skipped. So I studied again, came back with my basics. So now once you are strong with your basics, there's nothing going back. You just have to keep updating your knowledge. That's all. And I think once you're in hospital settings, you will get this knowledge through medical reps, or so many people will be conducting conferences, so you just interact with your fellow colleagues. So I usually participate in all the clinical discussions that is being held by the medical oncologists in Bangalore. So wherever is it, if I get a chance, I go there, because that's where you know how people practice, and like where you can give your input to them. So how you can like make changes as like a clinical pharmacist as well. So next, any questions from any of the audience?
ಮತ್ತೊಂದು ಹೊತ್ತಿಕ್ಕಿಂತ
Any questions?
But only eating.
You can unmute yourself and ask the questions if you have.
ಜಲ್ದಿ
Or you can,
ಬಂದಿದ್ದೀನಿ ಜಲ್ದಿ ಬಂದ್ರಿ
sorry,
Please mute yourself.
ಹಾ ನೋಡ್ದೆ ಜೀವ ತಗೋಬೇಕನ್ಸತಿ ಗಾಡಿ ಅಲ್ಲಿಂದ ಬಂದ್ರೆ ನೀವು ಇಲ್ಲ ನಮ್ದು ಬೇರೆ ಲ್ಯಾಪ್ ಅಲ್ಲಿ ಮ್ಯಾಪ್